Last, sorry. गाली दे रहे हैं वो मेरे को, गाली दे रहे हैं। Shit.
Which one? Which one?
देखो नहीं। Slides देना बेटा।
Last.
Please start the slides fast.
Yeah. I'm presenting clinical profile and management of 57 presumed ocular tuberculosis. 57 cases of presumed ocular tuberculosis were diagnosed on the basis of clinical feature plus any one of positive Mantoux test more than 10 millimeters or quantiferon TB gold or definitive signs of pulmonary TB by chest X-ray, CT or PCR on AC type. All cases were seen in southern Konkan area of Maharashtra in 3 years with a male preponderance and average age of 46. Excluded 4 cases diagnosed as HIV or already treated for toxoplasmosis, retrospectively received, and all received 6 months of ATT were only included. Constitutional symptoms were noted. Clinical findings were divided into anterior uveitis, intermediate uveitis, posterior and pan uveitis, retinal vasculitis along with a patch of choroiditis, neuroretinitis and endophthalmitis with a patch of choroiditis. These are few cases, different types of clinical presentations strongly suspicious of presumed ocular tuberculosis. So clinical presentation, the most common presentation was posterior uveitis, in which multifocal choroiditis was most common. The diagnosis was done with a 47% has positive TB gold test, 39, that is 92% had a positive Mantoux test, 7% had systemic problems suggestive of tuberculosis. Only one patient already received treatment of the active pulmonary TB cases. 3 patients had Mantoux negative but quantiferon gold positive. 4 patients has Mantoux test as well as TB gold negative but PCR was positive. So definitive signs were seen in 9 cases. 8 cases had definitive signs of active tuberculosis and 5 cases had definitive signs of pulmonary tuberculosis. So the investigation protocol we followed was, when we have a strong suggestive of ocular tuberculosis, we do Mantoux test first, followed by quantiferon TB gold test. If it is still negative, we go for PCR for ocular fluid in addition to CT chest and X-ray. So visual outcome, final base corrected visual acuity was better than or equal to in 38 out of 57 patients who completed at least 6 months of ATT. Of remaining 19, 12 lost 1 line vision and 5 lost vision more than 3 lines. Of that 5 patients, all of them have lost vision because of macular scar or edema. All received ATT for 2 months followed by 4 months of 2 drugs regime. 10 received subtenon tricot, 35 received systemic steroids, 12 received intravitreal bevacizumab, 4 laser for NV and 2 had undergone pars plana vitrectomy. Out of 12 cases, those who received anti-VEGF all had macula threatening lesion, 5 had secondary CNVM, 6 had choroiditis lesion threatening macula, 1 had macular edema post-occlusive vasculitis. Single dose of anti-VEGF helps in regression of inflammation and macular edema. 6 patients need more than 2 dosages. Can avoid use of systemic steroid and help in better effectivity of anti-tubercular medication. Anti-VEGF has a role in tuberculosis which has been defined in many journals now. These are few cases where patient had a multifocal choroiditis, then developed macular lesion with a CNVM, which was completely regressed with the 2 dosages of anti-VEGF, and we could, he was a one-eyed patient and could revive his one eye. So role of anti-VEGF causes significant, tuberculosis causes significant inflammation. Inflammation is sometimes more damaging to eye than infection, particularly if it is vision threatening where macular optic nerve is involved. Systemic steroid may be relatively contraindicated in active TB. Local intravitreal anti-VEGF has a rational use along with a systemic tubercular medication. So to conclude, ocular TB, even though rare, needs to be diagnosed with appropriate test and clinical criteria. Mantoux, quantiferon TB, PCR gives us clue for diagnosis, gives best clinical and visual results if started in time with ATT and steroids. Anti-VEGF has a rational role in sight-threatening lesion. Thank you.
Very nice, doctor. I think a good presentation. Thank you so much, doctor.
Thank you,
Thank you. Thank you
Very
so much.
nicely pointed everything.
Yeah, yeah.
Thank you, Dr.